So the basis for today's presentation is the research part. Because when we say research, basically we are trying to search for something new. If you talk in terms of the library meaning, it is something unused, something again, and something over again and over again. So something like that. And if you want to have a more scientific explanation or definition of research, it is a structured inquiry that utilizes acceptable scientific methodology to solve the problems and create new knowledge that is generally applicable. So what it means is, whatever we decide to find out, even something new, we should be in a structured format. And when we want to take that project forward, it has to be having an acceptable scientific methodology so that the problems which we are addressing are indeed solved and new knowledge is created that is generally applicable. So when I say generally applicable, it is not just for research purposes. It should be beneficial to the patient. So after all, we as doctors, as anesthesiologists, whatever we do is for the benefit of the patient. So any research has to be keeping in mind the benefits to the patient. And it's not just talking about the benefits. We should also be trying to find out that if some drug or technique has certain undesirable effects, side effects or harmful effects, they are minimized. So these are the things which we should be looking for. And when we indeed find something like this, it should be resulting in a change in practice. And second part is, so whatever we do, it should be brought to the notice of the larger community. So we should try to publish this research output also, so that we are not the final authority. Somebody else should also be able to critique our research. And of course, the primary reason in the last few years has been publication. Because NMC says, for appointments and promotions, we need some publications. So that's the reason we also speak about research and publication a lot nowadays. So when we decide to conduct research, if you can see at this illustration, there are so many different types. At least 34 types are displayed in this illustration. So we can broadly classify them as primary research and secondary research. The primary research would start from basic research. For example, you do something on animals, you do genetic studies, right? Biochemical studies, or even material development. For example, I want to create a new endotracheal tube or supraglottic airway. I should be testing those material also. So, but we don't undertake such type of basic research in our field. Okay, it's a different set of investigations. The second part is the clinical trials. So when you speak about clinical trials, it is more under the control of the regulatory authorities. So when we talk about new drugs, we say it is subject to different phases of trials: phase 1 trial, phase 2, phase 3, and phase 4. Okay, so they are mandatorily done under the guidelines of the Government of India. We have got ICMR, we have got the CDSUO, DGHS, and all, which are the authoritative bodies which can guide us to undertake this various steps of research. But the third type of research is the epidemiological trials, basically, where we have certain observational studies and experimental studies, which is more suitable for us to be discussing about and more suitable for us to be talking about and then implementing also as our research project. So these are three different types of primary research. And when we combine the data and the results from this primary research, we can compile them, analyze them, consolidate them in the form of systematic reviews and meta-analysis. So this is called secondary research. So our point of focus today is about epidemiological studies. So epidemiology per se is a science concerned with the occurrence, the frequency, the patterns, the distribution and determinants of health and disease in groups or in populations. So basically, we identify certain risk factors for some condition. When I say it is disease, it is not a disease alone. It is some outcome. The risk factors for the outcome, the causes for the outcome, the effectiveness of the treatment which we are trying to think about. So these three are the more important factors for any epidemiological studies. So when we have all these outcomes, the greater target is to see that the patient health is improved, patient management is also improved. So we have broadly three different categories of epidemiological studies, which you can see here. They are the descriptive studies. Then we have the analytical studies, and we have got the experimental studies. So we'll go a little bit further to understand what are these. Descriptive studies is they just describe the occurrence of diseases in terms of the place, time, and person. Then we have the case reports and the case series and cross-sectional studies under this category. The second set is analytical studies, where they go a little bit further than the descriptive studies. They try to assess the associations between the exposures and the health outcomes. We have got the case control studies and the cohort studies under this category. The third one is the experimental studies, which actually assesses the interventions by assigning exposures to individuals or groups and measuring the outcomes. What it means is you do something as an intervention, which is not seen in the other two types of studies. So example here is randomized control trial. So what we can do basically to understand further, the first two types of studies, first two types of epidemiological studies, the descriptive studies and analytical studies, can be grouped as observational studies, and the last one would be called as experimental study. Observational studies are the ones where nature determines who is exposed to the factor of interest and who is not exposed. Okay, and trying to demonstrate an association may imply causation or it may not. Okay, we don't do anything actively. So when we speak about experimental studies, the investigator, we as researchers, determine who is exposed to certain area factor of interest, right? And these studies, experimental studies, are more likely to be effective in terms of proving causation, right? So broadly, we have got the observational studies and we have got experimental studies. So if I list out the actual type of the epidemiological studies which can be undertaken, under the observational studies, we have got the case reports, case series, cross-sectional studies, case control studies, and the cohort studies. There are basically 3 plus 2, 5 types of studies here. Then under experimental studies, it is more commonly the randomized control trials which we speak about. Okay. So this list is also very important for us to understand, because if you start from case reports down, so we have this pyramid of evidence-based medicine, right? So at the lowermost part, among the list I am showing you today as epidemiological studies are the case reports, then case series as we go up, then cross-sectional studies, case control, cohort, and clinical trials. The case reports and those at the bottom take less time in terms of research, but they also are least credible in terms of evidence-based medicine. But as we go up to different other varieties, they need more time and they are more credible. So that's what we have to understand in terms of the evidence-based medicine. So let us start with an example here. This is about a 39-year-old woman, previously healthy. Patient was on 81 milligrams of aspirin and from early pregnancy, because she also had a high risk of preeclampsia. She underwent elective cesarean section at 37 weeks because of preeclampsia and twins. So in fact, on the day 0, her lab parameters were normal. So PTNR was normal, APTTA, platelet count was also normal, and basal parameters in terms of hemodynamics and everything was perfect. She was stable and she went at standard spinal anesthesia, and even there was no need for vasopressors. After 24 hours of surgery, patient developed certain symptoms, including headache. Gradually, there was a weakness in the right upper limb and the right lower limb. And the patient was subject to an MRI. At this point of time, there was nothing. Even the laboratory functions were within normal limits, including platelet count and the clotting functions. They thought it is just a transient cerebral ischemia. They put the patient on conservative treatment. There was no improvement. But after 48 hours, the patient's condition deteriorated. Then she gradually developed the left side paralysis, not just the right side paralysis. The right side, it became almost complete paralysis. And when they repeated the MRI at 48 hours, what they found was there was an epidural hematoma at C3 to T1. And they found there were no vascular malformations and no other damages except for this hematoma. So patient was subjected to an emergency laminectomy, C3 to T1. And even during around the time of laminectomy and after that period, day 6 to day 12 also, none of the coagulation parameters were affected, right? So this is a publication. So this was an actual publication, right, about cervical spinal epidural hematoma after spinal anesthesia for cesarean section in the parturient using long-term low-dose aspirin, right? So all of us know, for example, we say if somebody has got a platelet count of 75,000 and above, it's a standard, accepted level to go with spinal anesthesia. This patient never had any problem in terms of platelet count. And the article of case report also goes on to discuss these are the guidelines from ESTA and different bodies of regional anesthesia. It also discusses about the spinal hematoma and hematoma at the site of injection or away. For example, this patient was given a lumbar spinal, but the hematoma was seen higher up. And they also advise about surgical decompression early, right? So this is the case report. So what is special? So definitely there is speciality here. It's not just that everything was perfect and everything was outcome was perfect. Okay, so you will never get any doubt when somebody has got a very regular normal platelet count. There were no negative influences, no comorbids, but suddenly with only 81 milligram of aspirin, this event occurred. So that's the reason this case was reported. Okay, so the case reports generally are the basic types of research where the authors would try to present something new in terms of a disease diagnosis, in terms of its symptomatology, or in terms of an unusual course or new complications, or they have found a new possible association with some exposure or some new management also. And in fact, many of the inventions or innovations are initially published as landmark publication, right? For example, the earliest one, when we speak about the spinal anesthesia and local medication of the cord, this was the title of publication by Dr. Corney. Okay, so all of us know he's one of the earliest persons to instill local anesthetic into the central nerve axis. But was it spinal canal? Was it epidural? Okay, there was confusion. And there were subsequent case reports by Bayer and Taffier. And in the publications by Bayer and Taffier, they clearly mentioned that they reached the CSF and the drug was injected. And Corning, in this publication, never clearly mentioned that whether he reached the CSF or not. And he also says that onset of some weakness was slow, right? And it became patchy or unilateral, something like that. So it actually means that he never reached the CSF at all. And more likely, he administered the drug in the epidural space. Okay, so all of us know that subsequently we had the great revolution. We had spinal anesthesia coming to work, and it heralded a revolution in anesthesia practice. So this is the advantage of talking about case reports. We should never demean the case reports. And in fact, it could be the first step for novice researchers at the beginning of their scientific careers. So what we can do, if I am just into a PG or post-PG, it will help me to improve my academic writing. It will influence my critical thinking. It will expose me to high quality publication and how peer review is done. And I will also be able to collaborate with other people, including my teachers and mentors. So that's important, that it also helps in hypothesis development. In fact, a case report can lead to next level of studies and researches, including RCTs. In fact, one of the publications in Lancet says that over a period of 5 years, almost 25% of 103 case reports published in the Lancet were followed by registration or publication of RCTs. So that's the importance of case reports. Okay, so this is what is about case report. Then we'll go to second type of epidemiological research or the studies, that is called case series. It is just advanced, next level of case report where we don't have just one or two cases, we have multiple cases based on the encounter of the physician or the anesthesiologist. It could extend from anywhere from 3 cases to 10 cases. And sometimes some of them would also comment about doing more than 10 cases. So what are these case series? Just like case reports, it could be that somebody is experiencing or encountering a new symptom or sign or diagnostic tool or management tools or unusual cases also per se. And as I told you already, case series can also be a platform for a new type of research, right? Case reports can become case series, and case series can also herald new type of researches also for new inventions. And in fact, feasibility studies. So for example, we are just picked up an idea, or we want to talk about a new drug, or we want to talk about a new technique. If we don't have enough resources in terms of patients, in terms of human resources, in terms of even money. So we can have the case series as a feasibility study. And in fact, case series are better to report on those cases which are which are there in occur in low incidence. They are rare cases and they are costly. And we don't have large samples to work upon. So this is the advantage of doing case series. So look at this publication: single operator real-time ultrasound guided spinal injection using Sonic's GPS TM. Right? It is a publication where the authors speak about a novel needle tracking system using ultrasound, which benefits in correct placement of the needle in the intended block area, and it will allow for optimization of needle beam alignment. So they picked up about 20 patients posted for lower limb replacements, and they used ultrasound guided spinal anesthesia. It is spinal anesthesia per se. So they describe in detail what is this device, what is this needle, what is the ultrasound image in terms of its guidance, and the actual technicalities in the form of an illustration, right? So this is what we can see here. So what they concluded was this real-time ultrasound needle is possible. Okay, real-time ultrasound guided spinal anesthesia is possible with the new system and with an acceptable time frame. They also said it proved effective with a lower rate of failure and a lower rate of complications. And they also suggest that our clinical experience suggests that a randomized trial is warranted to compare the new device with a standard block technique. So this conclusion is so beautiful for a case series. They clearly say something new they have found out. They have found that it is feasible to use it and it can be used within a short duration of time. There is low rate of failure, low rate of complication. And they say in future, we can also have a randomized control trial. So this is what is the scope of a case series also. And why they are suggested like this is there are certain limitations of case series, okay, which will not help us to clearly say that this particular device is good. So they suggest that we can go forward with a randomized control trial to overcome all the limitations of a case series. So in fact, there are certain disadvantages of this case reports and case series. Okay, definitely. They go with certain bias because I am the one who has done some studies. I work with a certain mindset and for a limited number of patients. Okay, and I may overinterpret, and it may not be possible for me to generalize the outcomes out of these case reports and case series to a larger population. So that's what we have to understand. So what is our option now? So we have spoken about case reports and the case series. Then we have another set of the observation studies, the cross-sectional studies, the case control studies, and cohort studies going further. So the cross-sectional studies. So I think if we have interacted with our other colleagues in other specialties, this type of epidemiological studies are very common. Cross-sectional studies, the orthopedicians, the physicians, the surgeons, obstetricians, ENT people, everybody, when they submit the thesis topics and also publish, majority of the times, they publish these cross-sectional studies. It is actually called as a snapshot study, okay, wherein they talk about the prevalence of an outcome in a specific group, surgical group or medical group, and they are useful in showing associations, right? Basically, in providing early clues to the etiology, like causality, and they generally make comparisons at a single point of time. Okay, so for example, they say, we operated on this type of fracture with this type of procedure, right? Then the surgical, then medical colleagues say, we encountered this type of infection. So this many patients we encountered, we gave this type of antibiotic, culture sensitivity was done, these are the outcomes. Okay, these are the cross-sectional studies, and they make comparisons at a single point of time. It could be or a single duration of period. I mean, a limitation is there. It's not at a single point of time. We call them as point prevalence and period prevalence. For example, if you are measuring cholesterol levels and trying to say that cholesterol levels will come down possibly with walking. So we can compare, for example, cholesterol levels in people who walk and those who don't walk, right? They are come to outpatient, we just check them. So that is called a point prevalence. At that particular point, you are just found. So you will say you can even categorize them to under 40 and over 40, something like that. So it's called point prevalence. Or you straight away take them at second year, at fourth year. Okay, that becomes a point prevalence. That's okay with when you speak about cholesterol levels. But there are some situations where we need more time to accumulate sufficient information. For example, you supplement iodine as a public health measure over a year and look for the instance of goiter. So it becomes a period prevalence. Okay, this is what is meant by point and period prevalence. But anyway, it's not too important for people to understand. So what is important is to know the background in terms of the research methodology and what is its importance. For example, this is a published article related to anesthesiology, a cross-sectional study to compare anesthesia techniques employed for the conduct of upper GI endoscopic procedures in a gastroenterology suite of a tertiary care hospital. So it is self-explanatory. So here they picked up, this was upper GI endoscopy was being taken up, conducted in a tertiary care hospital. Okay. There were a set of patients where they had administered moderate sedation only. In another set of patients, general anesthesia was administered. Okay. And wide range, 18 to 80 years of age, and even wide range of ASA 1 to 5 were picked up. And they tried to, and it was a retrospective study, for example. They try to assess what type of anesthesia, whether general anesthesia was given or only sedation was administered for upper GI endoscopies. Okay. They wanted to assess the factors affecting the selection of anesthesia techniques in patients undergoing upper GI endoscopy, right? So they gave huge tables mentioning about the demographics of the patient, the ASA physical status, the type of the procedure, the complexity of ERCP, the number of comorbidities that the patient had, what happened during the procedure, what happened in the post-operative period when the patient was shifted to PSU or the ICU also in some cases. Okay, so we have a specified population, and we were trying to find out how many of them received sedation and how many received GA, and we tried to link them to the exposure or predisposing factors and to the outcomes. Okay, so this is called a cross-sectional study. So they have done at certain point of time that these are the things which have happened in that institution. So in fact, one of the examples of cross-sectional studies is, for example, the exit poll for the recent Delhi elections. So it will be something like that. What the pollsters had done was they reached out after the completion of the elections to a set of people, sample size was calculated, and then they came out with this data. So this becomes a cross-sectional study. That's all at some single point of time. There are also what are known as longitudinal studies. Longitudinal studies are the ones where data is gathered for the same subjects repeatedly over a period of time. It can extend for years or even decades. For example, I told you about cholesterol. So if you follow up on the walking pattern and the walkers and non-walkers for not just not at a single point of time, but follow it up for 2 years, 4 years, 5 years, and compare the data. So that becomes a longitudinal study. So imagine I spoke about the published article, the upper GI endoscopy, the practices of anesthesia and sedation in that hospital. So the authors can very well come out with another article in future, just telling that the longitudinal study over 5 years to compare anesthesia techniques employed for the conduct of upper GI endoscopic procedure in a gastroenterology suite in a tertiary care hospital, right? So this is how the longitudinal study is being defined. So next type. So now we have understood about the cross-sectional studies. Consider another type of study. So imagine you are working in a setup and you are working in a PSU, and imagine a set of patients who have been administered general anesthesia with endotracheal intubation. They have been admitted to the PSU after extubation. Okay, and they are there possibly for certain duration of time, depending on their condition, 1 hour or 2 hours or whatever. You want to find out the incidence of unanticipated tracheal reintubation in the PSU, right? Okay, so this we can do by analyzing the records for the patients who required reintubation in the PSU in that hospital. Then what we can do is compare this unanticipated tracheal intubation in a set of patients to another similar group of patients who did not. Okay, and then what we do is see among all the group of patients, how many of them had received neuromuscular block reversal per se after the initial general anesthesia, and try to find an association between inadequate reversal because neuromuscular block was not reversed properly and reintubation. right? So, for example, we have certain definitions here, nomenclatures. So we are trying to find an outcome. The outcome we are trying to look for is tracheal reintubation, right? This is what we are trying to find out. And actually, it does happen in a group of patients. That group of patients is called case group. And there are set of patients where reintubation doesn't happen. That is called a control group. And we are trying to link it to an exposure, something that is whether neuromuscular blockade was reversed or not. That is called exposure. And beyond that, we'll try to see the inadequate reversal and the reintubation as secondary outcomes. Okay. So this is where there is a small diagram here. We are talking about reintubation on the right side here as an outcome. Then you go back in time retrospectively. So you can see the arrow going in the reverse direction, right? The red one is a case group, means the set of patients who need reintubation. And the blue one is a set of patients who don't need reintubation. And in those who need reintubation, check how many of them did not receive an adequate reversal and how many received adequate reversal, right? And those who did not receive reintubation, check how many of them received adequate reversal and those who did not. Okay. And this is all based upon the reversal. That is called exposure. Okay. I hope you understand. Exposure means giving a drug, for example, reversal with neostigmine and assessing the recovery of the patient, or a technique. So somebody is subjected to some technique in terms of an outcome, or it could be genetics or whatever. So outcomes could be, for example, we are talking about the reintubation in this patient, in this set of patients, or it could be complications, it could be death also. So trying to go back in time after trying to detect the exposure for a particular outcome that has already occurred is called a case control study. And the second group is always called as a matched group, because I told we are trying to find out the patients who are reintubated. Okay. But what you should do is the other group where reintubation did not occur, these two groups are comparable. For example, if we are talking about general anesthesia and endotracheal intubation, so you have a set of patients who had undergone thoracic procedures and extubated. It's just for discussion purpose. And there are a set of patients with lower abdominal procedures, okay, who are also being managed in the post-operative unit. Okay, so we cannot be comparing those two set of patients. Or you don't compare a set of patients where one set of patients had an average duration of surgery of 4 hours or 5 hours, and with another group where the duration of surgery was only 1 hour, or a set of patients who had COPD and who didn't have. So this is called matching. So matching in terms of the age, matching in terms of the physiology, the pathology, and the intervention. So this is what is called as matching. So in fact, there was this publication which spoke about risk factors for reintubation in the post-anesthetic care unit, a case control study where they carried on this from 2001 to 2011. They went back in time. Okay, they tried to find out how many patients had reintubation. And they also concluded, they found certain associated factors for reintubation. There are certain patient factors where young patients, those with COPD, hypovolemia, were at greater risk of reintubation. Operative factors, I told you, prolonged duration of surgery, cardiothoracic procedure, anesthetic factors, certain neuromuscular blocking agent, ASA visitor status 3, all of them were more likely to require reintubation. Okay, so this type of studies are best studies as incidence studies. Okay, we can say this many patients needed reintubation. Okay, because in a particular PSU, and we can also try to link the cause to the outcome. So we can say they were not adequately reversed, so they needed reintubation. And advantage is you are collecting the data also for a fixed period. It could be last 2 years, 3 years, 4 years, 5 years, or also further, depending upon the context. But they are also subject to inaccuracies because after all, it is retrospective. So some of the data which should have been collected may not have been collected, or quality control may not have been there for these purposes. Okay, this is called a case control study. So going further, what about the next type where we follow the natural course of a disease or a condition or exposure and the outcome prospectively, right? So this is a diagram. So what we do, we talk about a cohort, means a group of persons with common characteristics or experience, or a group of patients or a certain condition. For example, all of us are sitting today in this present in this webinar here, because all of you are interested to know about epidemiological studies, and we are there teaching it. So this is a group of persons with a common interest. We are a cohort today, and exposure is I am speaking to all of you, I am addressing to all of you, right? And I can say outcome. I can say keep a post test and try to see that how many of you have understood, and how you can link exposure, my teaching, to your improvement in knowledge. So this is something akin to what is known as a prospective cohort study. Okay. For example, just to make you understand, you can have a set of patients who have got benign prostatic hypertrophy. Okay. So one set of patients may be subjected to robotic procedures, another set may be subjected to bipolar TRP. Okay. Then you can check the outcomes for continence, improved continence, or you can have just one of the interventions, means not intervention, we call it as exposure. They could be just subjected to robotics procedure, and another set of patients may be just put a catheter, and conservative management may have been carried out. Okay, so just to give an idea, this is one actual thing that can happen. So there is a publication in anesthesiology, a prospective cohort study examining the use of regional anesthesia for early pain management after combat-related extremity injury. So it's a published article where the authors studied, I think, American soldiers who were injured during the war in the Middle East. They wanted to study long-term benefits of regional anesthesia for pain management after combat-related injury. Okay, there are two groups of patients. Okay, one set of patients who were receiving regional anesthesia within 6 hours of injury, and other set of patients were not receiving. Okay, they were just observing. They are not allotted regional anesthesia to one group and not allotting to the other group. So they just collected the data forward that this many patients were administered regional anesthesia within 6 hours of injury, and rest of them not receiving. Okay, that's what was done. They tried to find an association between regional analgesia and the average pain intensity in the set of patients, and there are other secondary outcomes also. Okay, so this type of study, a prospective cohort study, will help us in following up the natural course of a condition or a disease or an outcome, and also identify the incidence of this outcome. Okay, this is important for us to understand, right? So these are called cohort studies. Just I have put the same illustration here. We have got war-injured group as a cohort. Then the exposed people is people who, patients who received regional anesthesia within 6 hours, and non-exposed group were those who did not receive regional anesthesia less than 6 hours. So what was the outcome? They wanted to find out the average pain intensity. So was it better in the exposed group or non-exposed group? Okay, there is always two groups here because these are observational studies and going forward in time. Okay, this is the design for a cohort study. So what is the difference between the case control studies and the prospective cohort studies at this point of time for you to understand? Case control studies, I told you, we go back in time. Okay, and go back in time means we have got certain outcome and diagnosis, and we go back in time, right? And the sample is from among those with outcome and no outcome or disease, because there is an outcome. I told you about re-intubation, and we go back in time. Okay, and we try to link, and the group separations are done after exposure. Exposure has already happened, and we are going back in time. Whereas in prospective cohort studies, it starts with exposure. Okay, we talk about exposure, regional anesthesia within 6 hours in injured patients. Then go forward in time in terms of an outcome, in terms of improvement in the pain scores. Okay, the sampling will start from among those with the exposure and without exposure. And group separation starts with exposure. I hope you are understood. And next, what is the benefit here? Case control studies can provide associations and provide early clues to the causality, whereas the prospective studies, cohort studies, are relatively better in terms of providing the evidence of causality as compared to the case control studies. And they are less subject to biases, because retrospective means we don't have any control. It has already happened. When it is a prospective study, probably there is lesser scope of all these things. And case control studies are very useful for rare diseases or conditions, or when the disease takes a very long time to become manifest. It's very important because we don't know something has happened, and we are going back in time and trying to find out what has happened. Whereas in prospective studies, they are more difficult normally and more costly, and especially if a disease or the study takes decades to develop or if it is very rare. So this is very important to understand. I spoke about the cross-sectional study where you just speak about the exposure and the outcomes at a single point of time or a period, or we go back in time with an outcome and try to link it to an exposure, that is case control study. And you have got a prospective cohort study where you go forward prospectively with an exposure and trying to reach to an outcome and trying to link them. So this is the difference between the three major observational studies beyond case reports and case series. So now we have understood about case reports, case series, cross-sectional studies, case control studies, and cohort studies. As I told you, they are very good in trying to find out the instance or prevalence of a disease or outcome, and even the prevalence of an exposure and how to associate, what is the association between these two. And to some extent, they could be good in finding out the causality. But there are also problems with these observational studies. They are not the perfect studies because there are other things which can come in between. So there could be selection bias. Okay, when I choose the patients, I may not be strict enough, right? Or in terms of interventions, which we call it as exposure, or there'll be lot of confounders. For example, when we do the study, imagine that region anesthesia study which I was quoting. It could be some patient is on, for example, long-term pregabalin for some other reason, or somebody is on long-term antidepressants which have got central effects also. So they are the ones which can influence the outcomes, right? So that's one thing which is very important to know, the presence of confounders in a study. Or there could be measurement errors, or there could be treatment bias also in a prospective study. For example, I think, for example, region anesthesia will be very good for the patient, and another set of patients with region anesthesia is not there. I already had a bias in my mind, so that it is going to work in this group and other group is not going to work. Okay, or I will say I will use ultrasound. For example, that spinal anesthesia study I mentioned as a case series, but it can also happen. So I say ultrasound is very good, and I go to the point where it is expected to act, and it is not good with the landmark technique. So there is also bias. And definitely case control studies are retrospective and we don't have any control of what has happened already. So these are the problems with observational studies. Okay. Plus, there are certain things which can happen in normal life and even in our anesthesia practice which occur by chance. And we don't have any control. So, and we don't have any methods to control, especially with these observational studies. So these are the various things that happen, and this can have to be addressed. So beyond the observational studies. So these can be done by randomized controlled trials, right? So we have a methodology in randomized controlled trial, which takes care of all these negative things which are attributed to the observational studies. We have got what is known as randomization. Like, for example, I select the set of patients to undergo some intervention. I told you randomized controlled trials are where we intervene, whereas the observational trials are we are letting the nature take its own course. We are not doing anything actively, right? So even when we talk about randomized controlled trials, we randomly allocate the treatment option or something in terms of technique or any other thing randomly to two sets of patients. So we don't have control over which patient is going to get which type of treatment or management or technique. And we also try to conceal the allocation of randomization. Even if I am the anesthesiologist, okay, I will not know till the final point of actual implementation which type of management I am going to do for the patient. And all of you know, we also try to blind in terms of patients, the clinicians, even the post-operative management. And there is also what is known as an alpha error, where we speak about false positives. Okay, and we also talk about the validated statistical analysis. So this is only available for randomized controlled trials as compared to the observational trials. So look at this published article. This is about combined proximal or distal nerve blocks for post-op analgesia after total knee arthroplasty, a randomized controlled trial. So this was a prospective study. Very important to know, randomized controlled trials are always prospective. They enrolled from December to May 2020 to 2021. They had two groups. There always will be two or more groups in randomized controlled trials. So there was a distal group, means the distal block options were used, IPAC with femoral triangle block and obturator nerve blocks. And proximal group was more the traditional one, sciatic, femoral, obturator, and lateral femoral nerve blocks were performed. And there was a background opioid sparing general anesthesia given for the patient. So what was the design? So I'm trying to just paste the article part here itself so that you understand better. They have written a computer generated random number table was used for randomization. So they undertook randomization. Then they have mentioned that allocation numbers were sealed in an opaque envelope and opened after consent was obtained by the research assistant. This is allocation concealment, right? These two are followed. Then they also mention that the PNB's peripheral nerve blocks were performed by a physician who was not involved in the post-op assessment, means he is blinded. The operating room anesthesiologists and surgeons were blinded to group allocation. They are blinded, as were post-operative care providers and outcome assessors, right? So this is called blinding. Multiple levels there was blinding. So advantage of this is each person would, in a neutral way, will carry on his duties, either in terms of choosing the patient, in terms of administering the block, or in terms of following up on the outcomes. So this is blinding. Then they also spoke about an alpha error of 0.05. So I just want to remind you, whenever we speak about studies here, we talk about sample sizes. In the sample size, we always speak about what is known as an effect size, that something we have certain hypotheses, null hypothesis or alternate hypothesis. We say one group, something will happen. In second group, it could be better than the first group, or in the both group, the outcomes could be similar. But we always speak about something as a false positive, right? So these false positives are normally kept at 0.05% or 5 by 100 or 1 in 20 patients. Means something can happen giving positive results in 1 out of 20 patients. So this also is clearly mentioned. And they have also clearly spoken about the statistical analysis. I said the randomized controlled trials are the type of epidemiological studies which are best in terms of validation by specific statistical tests. So this is very important statement. So they clearly mentioned about the quantitative variables being compared with student t-test or Mann-Whitney U-test. They say categorical variables were assessed using Fisher-Exact test and the p-value of less than 0.5. So these are clear indications that the standards were very high to overcome all the deficiencies, the whole list of 5 to 6 points I showed you, which were attributed to the observational studies. And they put clear tables here in this study, what happened at individual levels and at different times with respect to the pain scores. They gave clear p-values. They also mentioned about the surgery time, the need for supplementation of propofol, the sufentanil, and other things. So these are the important components of randomized controlled trial, which make them strong in terms of evidence-based medicine and nearer the top of the hierarchy of evidence-based medicine. In fact, we have this consort checklist. Actually, this checklist is for publication after a RCT is completed, but I have just put it here because there are almost 24 to 30 points which say that these are the important components of a randomized controlled trial, and these have to be ticked by you before you submit it to a journal for publication. So indirectly, it is giving you all the details of the quality and the importance or advantages of a randomized controlled trial. Okay. So in fact, what I can say is the RCTs follow the most rigorous tools to examine the cause-effect relationships between an intervention and the outcome. So they take care of randomization, allocation, concealment, blinding, errors, and the statistical analysis. And as I told you, in the pyramid of hierarchy of evidence-based medicine, they occupy the highest hierarchy in terms of the epidemiological studies. Case reports are at the bottom. As you go up, we have got the clinical trials and RCTs, right? So this slide may not be important, but just I wanted to highlight that even the RCTs we do, definitely they occupy the highest position in terms of telling that cause-effect relationship can be better established with these things. But if the quality is good, we say how rigorously we implement the methodology and all the techniques, means it is very strong in terms of design, analysis against errors, biases, confounders, etc. It represents the internal validity of an RCT. And if somebody picks up all your methodology and the technique and assesses your the quality of your research, and if these are generalizable to a larger population, it is supported as external validity. Okay, so this is just to make people sensitize that the quality of an RCT is represented by internal validity and later on external validity. So this is a probably the last slide for me. So we have discussed about observational studies, the case reports, case series initially, right? For important innovations or early treatment, early diagnosis or something new, these can be taken, carried forward. And we have cross-sectional studies where we talk about the relationship between a cause and effect at a particular point of time. Then you have got case control studies where we go back in time and try to link the outcome to an exposure. And we talked about cohort studies, which are normally prospective studies, where we talk about an exposure and try to link it for an outcome and try to find an association. And the best one would be the clinical trials or the RCTs, which I just spoke about. So thank you very much for the patient listening. Thank you very much, sir. Thank you, ICA.
Thank you very much, Dr. Bala. That was so clearly explained to everyone that I'm sure so many doubts have been clarified. Indeed, your lecture was so discreet. Thank you so much. Bhuvan, any queries or any clarifications from sir?
Sir, it was undoubtedly it's a very, very good lecture. And despite being this complex topic, you have made it very easy. And it was like, I mean, your lecture was like the warmth of Bhaskar of Uttarayan. So, sir, I have a few queries.
Yeah,
Like, India is known as the land of ideas. But despite that, we are not doing very good research as you compare to the West. Why it is so? And what can be done to improve this?
I think one thing, I am an optimist, basically, in the sense, as you have observed and I have also observed, and of course, Madam and Sir are in the field for a longer time. We were bad in terms of the research work, especially in medical field, including anesthesia. And gradually, because it was mandatory from by the MCI and the National Board of Medical Examinations, gradually we are all forced to allot the thesis topics to many of our students. And there was no certain degree of mandatoriness in terms of the research for the faculty in olden days. So one of the reasons our PGs were not able to pick up us also, but we were weak in the research field as faculty. And the resources available were definitely there in terms of clinical material, but resources in terms of support, in terms of drugs, in terms of devices were also not much. And third thing was overall, I'm not talking about the recent 10 years when we have got too many medical colleges coming up. But before that, all the medical institutions, we had too much of clinical material, and it was a very, very busy schedule for the trainees also as well as the faculty. So that was one of the reasons that research was not taken up. So because it has become mandatory by the NMC, it is being taken up on a improved scale nowadays. So the first part, I'm sorry to say, was initially it was a sort of ignorance at one extreme, and number two was a certain level of illiteracy related to research, And third one, at this point of time, I can say in 70% of institutions, it is semi-literacy. Okay. And what I am trying to say is the 30% of institutions and in the faculty pool, I think definitely there is a very good understanding of the research, why it should be done, how it should be done, and how it should be taken forward to the point of publication. And I'm very happy to say that exposure is very good in our field, anesthesiology. For example, classes like this conducted by ICA, and I have seen the research methodology workshop.
Yeah. Yes, Bala.
Something with the network, I think.
I think
Some
there's
network failure. Hello? Sanesh, are you
Hello?
there?
Yes, sir.
Yes,
Sir.
we
I
are
think
there, but
connectivity
I
issue.
think
Just
we've
we'll
lost
wait
Dr.
for a
Bala.
moment.
Issue. Yeah. Anyway, don't worry. I'll bridge up. Whatever Bala was telling, Pandey is correct. Because we started very late. Well, we are still to go further on all these particular matters. We are comparing ourselves with the 200 years old traditions elsewhere, say in the West or in the Far East. We are only 75 years old. And see, in medical statics actually started growing up only in 80s. I may say 80s only, not even before 80s. Probably when I was an undergraduate student, I learned about mean, median and all, but not beyond that level. So we are slowly growing on these particular matters. And again, the government of India or the medical education infrastructure are not providing that much of financial support to have this also grown up. Even today, you know, the pharmacology research taking place in India. Phase 1, phase 2, phase 3, phase 4 trials are the book. But actually, there are only very few molecules which are undergoing phase 4 trials in India.
Sir, I think Bala sir is back.
Yeah.
Thanks.
So can you hear me, please?
Yes, yes,
Yes, yes.
Now, I only suggesting that the various training sessions are now in vogue in the last 10 years. In fact, I have been a faculty not just for anesthesia group. I have worked with obstetricians. I have worked with surgeons. We have worked with the dermatology groups, and I have worked with Ayurvedic group also. In fact, there are experts in Ayurvedic field. They conduct better research than many of our allopathic departments. That also I have found. So definitely it is picking up. It was purely, as I told you, initial ignorance, then initial illiteracy in terms of what is happening. And gradually now, luckily, because of a push by the NMC, more and more people, including youngsters, are getting involved. And they are reflected by improvement in even the output. In terms of publication in Indian journals and publication by Indian authors in the Western journals with high impact factor, that's also happening. And in the thesis that are published among the PGs, all of us, majority of us are teachers also. When you look at the final thesis dissertation or the dissertation which is published, the quality is generally improved. Of course, a lot of things are still pending in terms of statistical things. I mean, we have got BCBR, which is conducted by Government of India for all the postgraduate students. But I think our faculty are not updated with the statistical aspects. So are the students. But in terms of research methodology, there has been a marked improvement. But that there are good quantitatively speaking, the quality of articles has not that much improved. That's one thing. Number of quality articles are not published as a percentage, but in terms of actual numbers, there appears to be some improvement. So this is my feeling in terms of the research mentality from our colleagues across the country. And a platform like ICA like this, I think normally, I hope they also go through the YouTube upload and try to improve upon their research quality.
I
Yes.
think if we'll start, in a good way, in a larger way, then we can provide very good data, very good quality data, and very large data, because we are doing very good. I mean, the number of surgical procedures in the metro cities as well as in the rural, we are doing very good, but we are not having data. That is the main issue. Plus, if you have some idea, like some innovative idea regarding some monitoring or something, but then we don't know how to approach and whom to approach. And by the time it is 1 or 2 years, it's gone. So that is the main issue I have seen when, a few pulse oximeter, new pulse oximeter with 7 waveforms. Most of them are Indians, but we are not doing it here. So this is the thing which we are lacking, and if we'll do something good, then we can have a very good data with the good support.
I definitely agree, because that point, I'm sorry, it was excellent point you picked up and shared with us here. We don't have data basically across the country, even though our associations are trying to do something. But all the onus is now on the government of India. It is trying to collect the data, especially for obstetric care when we do. Okay, lot of data is going there, and even the NMC nowadays, if you see the last requirement from NMC, they are asking about the exact type of anesthesia that is being given. The data is collected from each of the institutions. Hopefully they are correct. They are reaching the NMC, and it is going to help in build up of a database for anesthesia practices. That's one thing. And definitely innovations have gone up. I'm seeing a lot of innovation sessions in different conferences nowadays, and there are brilliant minds working in anesthesia practice now. And they are interacting with IITs and other places across the country, and they have come up with new innovations. Only thing is, what I'm trying to see is they also have to be guided in terms of publications and projections. So especially the airway devices were being manufactured and produced. So the logical way you have to take it up is, for example, of course, take the mandatory approvals. So what we are expected to do is do it on mannequins, an airway device, then do it on volunteers. Number 3, use it on a case as a case report. Number 4, use it in a case series, as I spoke about today. Number 5, it could be a cohort study. Number 6 could be a randomized control trial. In fact, there is an actual nice way where we can take newer innovations also, starting from simulations, then having done it on mannequins, then do it on volunteers, do it as a case report in individual cases, and do it as a case series, then do it as a prospective observations trial, and finally do it as a randomized control trial. So this is actually a simple idea, which actually have spoken to some of our colleagues. So acceptability becomes more within the country and outside the country also. So this is the place where research plays a better part with respect to newer innovations and bringing into market also. So marketing ultimately depends upon its safety profile in terms of any device or drug. Okay? So we have to build up this research backup and publication so that ultimately it comes to actual clinical practice.
Truly, Dr. Bala, that means even if our students write a case report, it should be appreciated, because that's the first step, and that's how they will go forward. So not to just say, why have you just published a case report? Go and do an RCT. They can't just do the double promotion. So I think this is so important for the teachers also to know, that encourage each and everything that the students do.
In fact,
Sorry.
No, in fact, we had to, of course, I don't know about the audience here. We have to start with the so-called correspondence and letters to the editor onwards,
Yes, yes.
go forward. So we get that scientific mindset. And when you put this is a correspondence or a communication, we are trying to critique a published research. Okay, then we are understanding the nuances of that particular research. That also acts as a base. Yes, Dr. Kumar.
I think there's a
Yes.
question there. Sorry, Bhuvan,
There are some
you-
questions.
There's one question there from Dr. Imran. Is ethical approval mandatory for publishing a case series?
Yeah, it is required. Number one, it is required for publishing a case series because you are talking about epidemiological studies and as anesthesiologists. I assume that this is related to patients only. So anything related to the patients, ethics committee approval must be taken. That is compulsory. It's a perfect statement. Number two is there is no question of not approaching ethics committee for any reason. The modern trend is anytime you have got doubt, you still go to ethics committee. Let the ethics committee say that permission is not required. Okay, because many of our meetings, people say whether it is required for this, that, and all. That ethics committee approval is not needed. That declaration has to come from the ethics committee only. It is safe and it is also the right way to go forward. And for case series, definitely also for that also you have to take ethics committee approval. It's true that it is an encounter. Yes, there is a case report because the institutional ethics committee also takes into consideration the privacy considerations, the confidentiality considerations, and because the ethics should not be flouted when the actual case series is getting published. That is a consideration. So you can reach to an ethics committee, tell them that I have done like this. Let them say approval is not needed, but generally they will say approval is required because whether you have taken approval from the patients for the publication of the data, whether the approval is taken for sharing certain photographs of the patient or patient's organs or tissues or patient's investigations. Okay, so that's the importance of ethics committee. You want to comment, sir, Pandey and Sood Madam, on this context?
No, I fully agree with you that best is because you have an ethics committee, you must approach them. Absolutely. It's very important.
And these days, the ethics committee is getting stronger and they give reports and they help in a large way. Only on very few instances where something has been done on the same topics, the ethics committee is not required. They gave a positive response on that particular matter. Otherwise, they really tear apart each particular proposal and give their opinion.
That's right.
Yeah, that's good.
The only issue, if I can share with you here, is some of the ethics committee colleagues are hesitant to approve randomized control trials. But what I want to share with everybody, because you may be knowing also, the NMC, I mean our ICMR, about 5-6 years ago has approved the academic clinical trials. With the same randomized control trial protocol, interventional studies are allowed for academic purposes as part of a thesis.
Part of thesis.
Yeah. It is clearly mentioned and approved, sir, but still some of our colleagues in different parts of the country, the input
probably they may not be knowing it actually.
Yeah, they will say no interventional studies. They want interventional studies at all, and they want to change the title also. Even if it is something interventional, they don't want it to convey in the title. Yeah, that's the problem there.
I think they may not be knowing it in detail. That may be the reason. We may have to make it published again and again.
Yeah.
And another problem is that here data isn't plenty, but even the ICMR is not that keen to record all the data. That's our problem. Probably it's not reachable at this particular stage. In another 4 or 5 years' time, well, more percolation is possible and more data may be able to come in.
Yes.
Yeah.
They are also improving, sir.
They improving
means in terms of actual interaction, feedback, and everything, communications have become better.
Yeah.
Yeah.
See, there was, except the name ICMR, there was nothing going on there till around 65, 70. And that time only it started slowly coming up. And we had to start from the very scratch.
Yeah.
Even though we are following the National Health Survey and National Health Project,
Yeah.
as the government of UK was following it there, we are also following the same line. But this static is somehow they dropped in between and was not growing up.
Yeah.
Whereas everything else grew well.
That is so, sir.
Yeah.
So why we can't do some study in rural areas? Because in rural areas, nothing was done.
Sir,
Even now, nothing is, I mean, they are not doing anything because most of the cases are conducted in rural areas. Metros are only few.
in rural area, even today, only clinical symptomatic medicine is practiced, nothing beyond that.
No, but for anesthesia, we can do how to improve their quality and outcome.
Yeah. So recently,
Sir, I agree. But our people should think of going on to the rural area, settling there and doing all this at least for 3-4 years' time. Once that particular attitude picks up, it will grow. Otherwise, it will be difficult. Because even now, the government is finding difficult to have enough support anesthesiologists or say primary physicians in the rural area. Not anesthesiologists, I mean, even the primary physicians.
yeah, some of our colleagues, younger colleagues, have expressed
Yeah.
interest recently. Dr. Pandey's query, some of our anesthesiologists in rural setups or peripheries, which we can call them, they said, sir, we want to do research.
Yeah, good.
So I have addressed them also. And definitely they can do. It's not that they can't do, because they have the knowledge nowadays. They have got the wherewithal to take up the projects also. But one of the queries they were asking was about the ethics committee approval.
Now we have good number of uneducated people who are not tuned to what is happening around in the major areas. I mean, the city life and the rural area life is different. It's on us. Anyway, I am an eternal optimist. So all will settle in another 10-15 years' time, provided the government is progressing in that direction. Rashmi Salotra, do you have any questions?
So,
Rashmi?
I personally, thank you, sir. I
Yeah.
personally wanted to ask one question from sir, which may be a little deviated from what we have spoken today. It is regarding some audits that we conduct at times. So, would the ethical approval be applicable for audits as well, sir?
Audits should be mainly in the form of a localized data collection tool and a follow-up tool for improvement in the working
Right.
conditions in terms of an institution.
Mhm.
But they are also publishable materials. Definitely one of the types of publishable material, including some entries in the registries also. Okay, so for example, you have a registry within the institution where you put up some data. That also becomes a research material which can be researched. So that way, audit can also be scientifically taken up, and it is ideal that you, again, as I told you for a few minutes ago, you submit it to the ethics committee, even though it appears innocuous in terms of not identifying any person or any patient, but maybe some investigation. Okay, then maybe some, when we talk about the medical material, in terms of tissues and other things, blood samples and other things, they are related ones. So it is advisable to convey to the ethics committee that this is the audit that is conducted and this needs to be published. So normally audit would be published after the follow-up and action taken. Right? So you've got certain audit on a certain field, you have identified certain deficiencies, and you decide within the institution and say that these are the things which have to be updated in the institution in terms of practice. And further, 6 months down the lane, 1 year down the lane, you will see again, meet in an audit and try to see what is the change. So at that point of time, we can submit the data in the form of an article and as an audit for publication.
Right.
Okay. So
Thank
it
you,
is an
sir.
acceptable format at that time.
Right. Thank you so much.
Thank
And besides this, I don't see any questions in the chat as of now. There is just one comment which says that it was a lovely talk and discussion, and they are thanking the presenter. That's from Dr. Murlidhar Kanchi, sir.
Yeah. Thank you very much.
Yeah.
Murli, are you there? Well, Murli,
No, no more questions, sir.
Murli is not able to be located. Murli, are you there?
Yes,
Because-
yes, I am very much here. I'm listening to the
Yeah.
conversation.
You want to comment something, Murli?
Yeah. Only thing I would like to say that I think Bhuvan asked why there is not much of research in India. I think when we enter the medical college, there is no stress on innovation, and the thinking process is such that we are told to learn the techniques and read and reproduce it in the exam, but there is absolutely no stress on innovation, and I mean, critical thinking is not stressed upon. So our mindset is only to do the clinical work and get out of the place at the end of the day. So unless we do something at the grassroots level, at the MBBS or the postgraduate level, where our boys and girls are taught to think critically and have some, I mean, innovative ideas, this will remain like that. That's my opinion, because this is my personal experience. When we did post-graduation or MBBS, nobody, we are asked to mug up and reproduce.
Absolutely correct, Murli. When we were joining, so think of 40, 50 years back.
Exactly.
At that time, something was told to us. We believe in that. Learn it, mug it up,
Yes.
reproduce, and skill also. We learned a skill and we are out in the market.
Right.
And we are there to practice what we want. But beyond that, we were not thinking further. What
Exactly.
should be the ultimate idea? Because a rechange has to come in all these particular matters. That means what do you want in 10 years' time or 25 years' time? And such sort of thinking is going to come, well, the growth is going to be poor.
Yes. And the other
Very-
point, Bhuvan pointed out the data, lack of documentation and data.
Lack of documentation only, nothing else. We have plenty of data.
Major
Nobody-
issue.
Yeah.
And nobody wants to submit the data.
Yeah. See, data preservation is absent in the healthcare sector. Only in the academic areas, well, data is to be some extent preserved. Data is
Yeah.
very nice, but not in health sector. Nearly 20 or 25% maybe in the academic sector. The rest is general healthcare sector. There, except in the major private hospitals, recording or data collection is very poor.
Yes.
All these things have to improve.
Thank you. Thank you so much.
And we may improve. We may improve.
As you said, mug up and reproduce. This is what is going on in the childhood age right now also. Too much of homework, and they are losing their creativity.
Yeah.
Yes.
So
Yes.
from where they will create? They should have the free mind.
That's the difference in our country and abroad. The whole style of teaching and education is different. So I guess we should be just optimistic and hope things change in the country.
Yeah.
They learn from us and they are teaching us now.
Further, we may have to go into some other grassroots area. Even today, well, 2025, we are still not sure what should be the national language of correspondence, national language of conversation, national language of appreciation. Well, even today, some people say about Malayalam, some Tamil, some Hindi, some English. Well, we know about the deficiency of each language. So these things have to be sorted out. But the political masters will never allow. They don't want all these things. And I don't want to get into all these particular values. I request Dr. Jayashree to go ahead further.
So it's my proud privilege to propose this vote of thanks. And I must say, we have been honored to have Dr. Bala Bhaskar with us today on this very, very important topic, which he's the master in India. The master in this, and also how you do a journal club critical analysis. And I must say that we are honored that you were here. Everything was so clear and crystal clear, I must say, that we are really very happy. And you said everything, explained everything so simply that it was a cakewalk, but we know it takes many, many years to reach this stage. So Dr. Bala, thank you so much. And we hope that you come on this platform again. You're such an important part of our college. Thank you so much. And thank you, Rashmi. Thank you, Dr. Radhakrishnan, Dr.
Thank you,
Bhuvan.
ma'am.
Thank you so much. Thank you, Rupsa. And thank you, Rashmi. You have Dr. Abhirup
Abhirup.
with you. Yeah.
Yes,
Thank you
ma'am.
so much.
Abhirup.
Thanks, Dr. Kanchi. Good night, everybody. Thank you, Dr.
Namaste.
Bala.
So thank you so much everyone for giving us the opportunity to host this session. So with this, we are ending today's session over here. Thank you so much and good night.